is Professor Shalini Kumari. Orbital floor fracture, myriad of presentation and customized approach of treatment.
Good morning. My topic is orbital floor fracture, myriad of presentations and a customized approach of treatment. Through this case presentation, I want to highlight that as a surgeon, we always want to do surgery, do some surgical intervention, but sometimes it's better to hold back, do observation. So our patient, 34-year-old male, post road traffic accident 1 day ago, he came to us with swelling and pain in left eye. On examination, he had periorbital swelling, ecchymosis in left eye, and in ophthalmos was less than 2 mm. Vision was 6/6, no RAPD, no diplopia, and ocular movements were full and free in all gauges. Coming to palpation of orbital rim, it was normal, no crackling sensation, subconjunctival hemorrhage in left eye was noted. This is the ocular movement in all gauges. So the patient was seen in emergency department, airway, breathing, circulation was normal, and there was no episode of nausea or vomiting. We asked for CT scan of orbit, both axial and coronal curves, to rule out any fracture. Serial sequence of coronal section of CT scan showed fracture floor of orbit, the posterior extent of which turned out to be quite close to optic nerve on coronal section. This is the axial section. This is the 3D reconstruction. Since we have a CT facility in house, so we went ahead and looked for sagittal section also. The image is not over here. This report says multiple depressed fractures were noted in left maxillary antrum with the defect measuring approximately 1.2 mm to 11 mm laterally with soft tissue protruding into the antrum. Another fracture was noted in the floor of orbit with defect measuring approximately 5 mm with soft tissue structures and air loculi extending through the defect into maxillary antrum, causing mild impingement of inferior rectus muscle. This was a radiologist report. Depressed fracture was also noted in the roof of the orbit, and there was retro and periorbital soft tissue and fat strandings noted. So neurosurgeon's opinion was taken for fracture of roof of orbit. They said that no intervention is required. Regarding oculoplasty opinion, we wanted to do wait and watch as the risk of surgical intervention and subsequent possible complications with vision loss outweighs the benefit of restoring normal floor anatomy with implant, in this case in our hands. So we wanted to reevaluate after 2 weeks. Patient did come after 7 days for fundus examination, which was normal. When patient came after 2 weeks, periorbital swelling had subsided, and in ophthalmos was almost nil. And this is the ocular movement post 2 weeks. On 3rd week, actually, since radiologist has said that there can be inferior rectus impingement, so we wanted to make it sure whether we want to intervene, and we'll just go for follow-up observation. We did a force reduction test for inferior rectus of the left eye, which was negative. So patient after 30 days was almost normal. This patient has been under our follow-up for last 6 months and is normal. So coming to literature review, we all know that myriads of presentations can be seen in orbital floor fracture cases, like they can be asymptomatic, or there can be cases of diplopia, enophthalmos, hypoglobus, hyposthesia, or sometimes entrapment of inferior rectus muscles. Regarding possible complications of surgical intervention in cases of orbital floor fracture, in certain cases, not in all cases, permanent loss of vision is also seen. Sometimes because of the direct deep insertion of the implant, impingement at the orbital apex, or retrobulbar hematoma. Now coming to clinical recommendations for repair of isolated orbital floor fracture, it is recommended that surgery can be taken within 2 weeks in cases of symptomatic diplopia with positive force reduction, and if there is evidence of orbital soft tissue entrapment on CT, or large orbital floor fractures that may cause latent enophthalmos. So the same study says that observation can be done in cases of minimal diplopia, not in primary or down gaze, with good ocular motility and with no significant enophthalmos, which approves our approach. There are articles which disapproves our approach, and so the take-home message is, in cases of orbital floor fracture extending close to optic nerve with soft tissue prolapse but with no restriction of motility or no diplopia or mild enophthalmos less than 2 mm, observation is a better approach compared to surgical intervention considering risk-benefit ratio. Thank you.
So, do you approve of the same thing? Say we should delay the intervention, surgical intervention, if there is no complication like diplopia or orbital nerve compression.
Yeah, we also follow this. Everybody follows, I think, the same approach. If inophtalmus is less than 2 millimeter, if the patient doesn't have hypoglobus of more than 2 millimeter, or there is no diplopia in any of the gazes, at least in primary gaze, then we start with oral steroids and review after 2 weeks. And if the patient has none of these, in fact, initially the patient may not have inophtalmus at all because of orbital inflammation and hematoma. Once that resolves, the patient may manifest inophtalmus and hypoglobus. So at the end of 2 weeks, we review once the inflammation component has subsided, and if the patient still doesn't have any significant inophtalmus, hypoglobus, and the orbital fracture is not large enough to cause it in the delayed setting, we do nothing. Otherwise, we immediately intervene and then do the floor implant.
If there is anaphylmos, we should.
Yes, if there is more than 2 millimeter of inophtalmus, or even less, if the patient is very keen on surgery, then we can definitely do. And in a posterior fracture, if the patient is keen on surgery, alleviation of inophtalmus and hypoglobus, we can simply prepare the anterior and the middle portion of the fracture, and we don't have to put a deeper implant to cover the posterior extent of the fracture because there is no incarceration.
Thank you, sir.